Hey, everybody, this is Erica Mello, and welcome to podcast episode number 34. In this episode, Susan and I talk about a patient of mine who is actually a fitness instructor here in New York City, and she was super hypermobile, suffered from persistent low back pain, and just wasn't getting better. And we talk about the clinical reasoning process, how to end up treating a person like this, and what the hypothesis was for why she was resorting to this overactive movement pattern that she had for so many years. We talk a lot about some treatment options. It's a great podcast, and we really hope you enjoy it. And also, happy Thanksgiving, everybody. I hope everybody's going to have a wonderful turkey day and enjoy and be with their families. And also, just want to mention that my wonderful co-hosts, Susan Clinton and Julie Wiebe, have an amazing course called From the Glottis to the Pelvic Floor, Make the Clinical Connections. And they are having an awesome Black Friday sale. So if you were on our newsletter, please, the newsletter that's going out for the podcast, you will have a link to that awesome course with a discount code, and it'll be 35% off. And that sale will go from Black Friday to Cyber Monday. It will end Monday, 12 midnight Pacific Standard Time. So if you are not subscribers to our newsletter, you must opt in for that on our website, toughtotreat.com. If you opt in, you will be on the newsletter for the podcast that's getting released, and you will get that discount code. Okay? Hope you enjoy. Happy Thanksgiving again. Hey, everybody, this is Susan Clinton and Erica Mello, and welcome to podcast, I think it's 34 maybe? I'm losing track, but welcome. How are you, Susan?
I'm good. Erica, how are you?
I'm good. Good.
On this holiday week.
I know, and we had like a horrific, in New York City, we were supposed to get like 1 to 3 inches of snow on Thursday. Well, we got 6 inches and the entire city was at a standstill. I've never seen anything like it. It was horrific. And our mayor is taking a lot of heat in the press because there was just no management at all. But
anyway.
I
heard kids were like sleeping at schools and,
crazy.
All kinds of stuff went on.
Yeah, it was not good. Not good at all. People took like 3 hours to get home from work or 6 hours. And now I'm looking out my window and there's like zero snow, which is so typical of New York. You lose that winter wonderland feel within 24 hours unless we have a massive massive snowstorm. Okay, this patient is a really interesting one. I always say they're interesting, and I know I do, but I treat a lot of hypermobile patients, which I know you do as well. And I think for me, they're somewhat tough to treat. Pardon the pun, but they are tough to treat, I find. So this patient is 24 years old. It's female. She initially came to see me back in August for left foot pain. She's a fitness instructor here in New York City. And so she didn't come in consistently at the beginning, to be honest, it was for her foot. So I took a look at her briefly after some classes and ultimately ended up doing some taping to her foot. Didn't see her officially in the office, just 1 or 2 visits. So that got better. She returned to see me in September, like a month later, for some low back pain she'd been having pretty consistently. She is also short. She's not very tall. I mean, she's not. I mean, she's probably like 5 foot, maybe 5'1".
Mm-hmm.
And she had prior physical therapy, and she had steroid, and I don't think she had injections. I think she took the oral steroids. They did not help at all. And she was saying that stretching, I'm like, oh no, don't tell me stretching helps you, you're hypermobile. Stretching her hip flexors makes her feel better. She was getting some medical massage as well. The woman was probably working on psoas, doing some psoas release. She also loved yoga. And I'm like, why do people who are hypermobile always do yoga? And her big issue with the yoga is that she couldn't do a lot of the twisting without kicking in her low back pain. Her back pain was pretty much bilateral, but it would switch. One day it'd be either right, The next day it would be the left. So I don't know what you think, Susan, but when I see patients saying, then it's the right, now it's the left, there's some level of a control problem there, like a
Hmm.
hypermobile. Wouldn't you agree when it's constantly changing like that?
Yeah, when I hear those stories, I kind of think that what we have is a system that's pretty transient. And so one direction may work one day and another direction may not work as much the other day. And I'm not so really sure that it's like the joint slipping in and out of place, but I agree with you. I kind of think more of this is maybe, a little bit closer to more, if you want to think about it that way, less of a global problem and more of a segmental kind of control issue, like motor control.
Mm-hmm.
I find
Mm-hmm.
it interesting too that I think people gravitate to the exercises that they feel like they can accomplish easy. And so a lot of people who have what quote hypermobility syndrome, if you want to put it that way in those kinds of terms, often gravitate to sports and activities in which they feel like that they can accomplish well. And so I think the reason that they go to yoga is because they can move well. I mean, they actually they're flexible. A lot of people who are stiff tend not to go to yoga, which would be actually good for them,
Yep.
to get them moving in different ways. That but it's not so much that I worry about them going to yoga. It's again, it sounds to me like with rotation, it kicks in her back pain. So to me, it's kind of like, ooh, maybe you need a little bit more time and input on how to control some of those movements a little bit better, so that they're working and doing the yoga without trying to bring their staying out of symptoms,
Yeah.
kind of as well too. So what'd you find?
So what I ended up doing with her, the main issue, she couldn't sleep at night. I mean,
Mm,
in the morning was worse. Sitting was kind of aggravating, and ultimately the fitness instruction she does part time is spinning, a spin instructor as well. So when you're sitting bothers you and you're sitting on a bike for a period of time, that's kind of tough. And I think it was more the transition from off the bike onto the bike, off on, that up down sit stand on a
mhm,
bike. um so just, but no other past medical history, no other medications, etc., no imaging, so nothing of relevance there in terms of any red flags. She's 24. So what I took a just quick look at her. She's like obviously in sort of an anterior pelvic tilt with that lordosis, that classic sort of dancer posture, which is what she did as a child. So one thing to note here, and it'll come into play when I tell you some objective findings I had. She was taught when she was dancing. I don't even know if with the type of dance. I don't think it was classical ballet. I think it was more like hip hop and things like that. She was taught to disassociate her thorax from her low back and her pelvis by shearing one to the right,
mhm,
one to the left. So, literally keeping her lumbar and her pelvis stationary and shearing the thorax over the top of the pelvis. And she did that very often.
mhm,
So I think she created some form of a hypermobility. In standing, I noticed like a hinge, like at L1, L2.
mhm,
And she also complained occasionally of bilateral quad pain. Just like a she called it a stiffness, but she wasn't stiff. It was just and it probably wasn't pain. It was just more of like a weird feeling. She told me. So I said, let me see how you move. And I looked at her standing, and she had your typical issues. And her center of mass was actually pretty okay. She had some issues with her hip where she was in this pelvic rotation to the left. She had her upper body was sort of rotated to the right. It's not unusual for someone who's hypermobile. Their systems are just trying to figure it out. So I basically had her, I just said, let me just see how you move. Do a lumbar forward bend. And she literally, when I tell you, she went down like a tree, like
mhm,
no segmental flexion at all. I'm like,
mhm.
can you do a roll down, drop your chin? And she literally got maybe 20%. Could not even do that at all. I mean, she was so geared into into the paraspinals. Like she literally was like timber falling.
Mhm.
She couldn't flex her lumbar spine.
All the flexion happening at the hip.
Yeah,
Yeah.
yeah. And very common.
Mhm.
So in standing, I said just do a twist in standing, just because she said twisting bothered her. I didn't see anything; it wasn't provocative. So I ended up just with that movement alone. I did some compression patterns because just by looking at her, you can in her story, she's extremely hypermobile. So I did some posterior compression, like I've talked about in other podcasts, where I put my hands on top of the iliac crest or a little bit lower, and I just do some gentle bilateral posterior compression with my hands, and I had her forward bend. And she was like, "Oh, that feels much better." I'm like, "Of course it does." Then I went to the back. I did anterior. I'm sorry. I went to the front. I did some anterior compression there. She felt okay. No pain, but the posterior was better. So I knew she needed some form of stability. So I ended up I ended up testing her thoracic rotation because once again, that was a complaint, the
Mm-hmm.
twisting. It was pretty normal. She did not have any symptoms at all, which is not unusual, right?
Mm-hmm.
Um, I didn't do any kind of, actually, I take that back. I had her back in standing. So I'm just going through my notes here. I said, let me just see how you bend, side bend, lumbar, back bend. I mean, when she did a back bend, I don't normally do all those in one, like, I don't test all of those anymore, but she back bent. I mean, she was hinging, hinge. I mean, she could have gone to the floor. And then same with side bending. She was hinging at that L1, 2.
Mm-hmm.
And some of those were provocative, but the forward bending was the worst. And her main issue was sitting and also just lying on her back at night. She had a hard time sleeping, to be honest. And she does sleep sometimes lying on her stomach, which is probably not the best for her. So just based on that, I'm going to get your thoughts, and then I'll go into what I actually found when I got her on the table.
So were her extensors overworking?
Yes, her QL, mostly her quadratus lumborum, and it's secondarily to her extensors. Yeah.
Okay. So she wasn't able to shut those off when she forward bent or rolled down or
No.
anything like that. So she was really, so that was probably the reason she was hinging so much, is because if you have those muscles overfiring, she can't really move her lumbar spine. The question is, why isn't she moving? Did you look at combination rotations with her? I know you looked at some twisting and standing and some twisting and sitting. Did you look at
A quadrant test, things like
yeah,
that.
yeah, or any of those kinds of things to see if the combination is what brought her symptoms on? I'm just thinking of the yoga poses, how they'll rotate the body one way and the thorax the
They'll
other way,
extend, right.
to kind of like, because sometimes with hypermobile patients, and I know you've seen this a lot, are people who have a lot of mobility. You have to twist them up a lot further than the normal person
Yeah.
in
No.
order to get their symptoms to like really, really jump on.
Yes. No, actually, I know I did not do that, but that's actually a great point. Because I was getting the lumbar forward bend and the back bend, side bending, it
Yeah.
was provocative. I
Hmm.
didn't, but that's actually a very good idea because you're
I
right. I
think,
mean, she's super, super, super flexible.
yeah, and she can hinge all the way back. The other thing I think is very interesting is she likes to stretch the anterior portion of her body.
Mm-hmm.
They call it a hip flexor stretch, but we're just stretching the anterior portion of the body, quite frankly, and that feels good to her.
Yep.
And she's really moving a lot at T1, T12L1, and all of the sensory input to the front of the hips and the pelvis all come from T12L1. So
Yep.
you think about the extensor muscles being so tight,
Mm-hmm.
are not tight, sorry, overworking, over recruiting, and the QL being over recruiting. It makes me also wonder, and rotation brings symptoms on, I'm just kind of wondering what's actually happening with those trunk nerves, if they're getting kind of caught up in some neural tension here with this as well,
Mm-hmm.
with the
Yes.
twisting part. And she and that, because that's the input, that's a sensory input to that area.
Yep.
So if that area is getting a lot of input from a lot of movement at T12L1, that could be one of the things that might be making her have that kind of weird feeling in the front. Here's the thing
Mm-hmm.
that I find most interesting at all about her is that sitting bothers her,
I know, right?
because sitting would put them in a bit of flexion and make them, and actually for what I've seen with a lot of people who spend a lot of time in extension, the one thing they like to do is sit and actually draw their knees up,
Yes.
so put their foot on the chair as they're sitting for a way of comfort. And she was getting some, so it'd be interesting to know how she looked on the bike
Yes, I've
and
seen her.
how she looked in sitting, because if she didn't allow herself to maybe she sat around, I don't know what.
So
I'll let you
yes.
talk again.
Yeah, no. So when I pressed with that, like she did say lying on her back, bringing her knees to her chest makes her feel better up to a certain point.
Right.
And when she said sitting, I said, is it sitting, the act of sitting,
Mm-hmm.
or is it getting up and down from sitting? And she said, well, both. However, what makes her worse is the movement from a sit to stand, especially off a bike,
Ah,
right?
okay.
Or
Yeah.
on a bike.
Mm-hmm.
And also just, and I've seen her, she's very much shifted to one side. I was probably her right side. Um, but it's the transitioning. It's that the
Mm-hmm.
hypermobility, they can't control the movement. If she's sitting for 20 minutes or whatever, then she gets up. That's the main issue for her, is she cannot control that movement.
That makes a lot of sense now. And
Yeah.
especially I'm thinking about her on the bike. How did she, well, you'll get to that, I'm sure, but how did she look on the bike?
She basically had, so she's small, right?
Mm-hmm.
So the bike fit, I'm assuming, is pretty good. We never can assume that, because the bike fits sometimes need to be adjusted, but let's assume
Mm-hmm.
that was okay. It's when you're sitting on a bike, because I do a lot of spinning, you're more, really much more forward, right?
Mm-hmm.
But when you're teaching a lot of classes or doing a lot of fitness instruction, taking yoga, especially with her movement pattern, she was not sitting in a lot of flexion.
Yeah,
She
okay. That's what I was thinking.
off
Yeah.
those sit bones on the
Yeah.
bike with the hands in front and probably in an interior tilt.
Yeah.
That, because I can't see her from behind. I didn't see her from
Mm-hmm.
behind, but that's exactly what she was doing.
Yeah. And that would make sense then why that was bothering her, because it was feeding into the same pattern. So it may not be that, it just sounds like she was, really developing a good sensitivity around those segments in her back there. And the compression through her lumbar spine was what was getting her. When you took that away by adding some compression into the pelvis, down into the
Mhm.
legs, so that she didn't have to work so hard in her lumbar
Mhm.
spine,
Mhm.
then that kind of actually eased things up for her a little bit. So that
Correct.
begins to come together as a better picture here.
Yes, yes, and I do think that ultimately with her, it's you know it, the sleeping also was bothering her, but
Mhm.
she sleeps a lot on her stomach, which makes sense, and because she's
Mhm.
really hinging there. So we talked a little bit about sleeping and putting pillows and things like that. But when I actually got her on the table, I said, "Let me just take a look at your back, and I'm just going to do your basic." Passive accessory for T-Pro mobility, your PAVM. I mean, she's
Mhm.
super hypermobile. I did that purposely. She's not really provocative, a little bit, but really hypermobile, and L1, L2, if not more so. Bilateral quadratus lumborum, really jacked up. Bilateral psoas, jacked up. I'm like, that's the only thing that's holding you together. That's why you feel better. You feel better short term when someone releases your QL and your psoas, but you're going to resort to the same strategy once
Yeah.
you walk out of the
Yeah. It's not
office.
lasting. Mhm.
Not lasting. And I said, you can still do that, and that'll be great. And if you don't, if you take away vacation, you'll be okay, and you don't do these movements over and over again. But ultimately, you have some form of a control problem, is what I was telling her. And I ended up, when it was interesting, because when I had her sort of do sit to stand in the office, I don't have a spin bike in the office, but when I had her do the sit to stand, putting her arms out, I wanted her to hold on to something, because you're holding on to the handlebars when you're spinning.
Mhm.
So she was pretty much, clipped in, hands on the bar, sit to stand. She'd really shift to the right. So her rib 6-7, or her rings, as we like to call it with LJ and Diane, rings shifted to the right, right? So okay, I'm very similar on the bike. I'm way over on the right. I know I need to get back over. I'm very aware of that. And I think making that clear to her and making her more aware of that, when she is on the bike and when she's teaching, she can get herself back to the center, which has helped her. So when you
That's
have some,
interesting. When she stood and you were working with her, did she shift off to the right?
yes, yes,
Okay. So it's
yes,
the same pattern you see onto the bike.
yes, yes,
Okay, cool.
and
Yeah.
you're clipped in, so, and your hands are on the bike, so it's kind of hard for you to compensate. You got to, so, and because when she was younger, she was so used to disassociating the thoracic spine, she
Right.
shifted right and left, like,
Like
and
crazy.
yes,
Mhm.
and she could do that very easily. because
It's almost like the people who sublux their shoulders as a habit. You
yes,
know, the ones that we talk about, that's actually a behavioral problem.
yeah.
You know,
Oh,
for chronic
interesting.
shoulder subluxers, you know, that
Yeah,
it's because, you know, they start doing it and it becomes this thing that they do all the time. And I know in the ortho sports world, they call it almost a behavioral problem,
that's
you know, to get
interesting.
them to stop it
Yeah,
because it's, you know, it's not, I don't know if there's any research saying it's good for the shoulder or not, but I guess if you keep pulling it out of place all the time, it can't be helpful.
right.
So, you know, it kind of makes me kind of think about that as, you know, it's not, I don't think she was doing it on purpose, but she was just doing it because she could so much. That was
Yeah,
something that was,
yeah,
it's a pattern in her
yeah,
brain, you know,
yeah,
that this is where I move. I move from here. I was taught to move from here at a young age, doing all the crazy fun dancing I was doing. But now maybe it's not serving me so well on the bike.
right. And exactly, and that is why I think it's so important to home the importance of prior injuries or prior. I mean, I dig deep into like, what did you do as a child? What did you do? You know, what
Mm-hmm.
injuries? That is so important because 9 times out of 10, that is relevant to their current situation.
Mm-hmm.
So, and she didn't volunteer that information until I stood her up. So I was digging into the history, but I wasn't getting that. Oh, I hinged when I had her stand up. She's like, oh, I did this. So it was like ringing a bell in her head. So,
Mm-hmm.
you know, you do the best you can when you try to interview somebody and grab information that you think is relevant, but that doesn't stop, you know, after the first visit or even after the initial interview. While you're working with them and assessing them, you could say, did you do this? Or, you know, it continues. It certainly continues. So,
Mm-hmm.
so based on that information, um, I was like, look, I can release your psoas. I can release your, I'm easy. I can do that. I'm a manual therapist. I can do that all day long, but you need to change your strategy. Ultimately, that's what you need to do. So initially, what I ended up doing was I taped her, of course, because I tend to do that on the first visit. Um,
What'd you
so
tape?
say again.
What'd you tape?
I did the posterior compression, the pelvis.
Okay.
Yep. So I think we've gotten some emails about that tape. We probably have to put that up on the website, but it literally, you know, piece of hypofix on one, right below right, like literally on PSI. So I wrap it around, hypofix on one side, hypofix on the other. I put the leukotape on top and then on both sides. So she's
Did you go
literally
lateral to medial or medial to lateral?
lateral to medial.
Okay. Yeah.
Yeah, lateral to medius for the
Mm-hmm.
posterior. So she felt pretty good, no problem. And then I didn't see her for 2 months.
Okay.
Okay, because of whatever scheduling or whatever. I mean, I think that people who it's human nature. The tape felt great. I feel better. You know, that type of thing. I'm going to go about my business. And then she came back 2 months later and she's like, I felt so much better, but then my schedule got in the way and it's just killing me now. And I'm like, well,
Mm-hmm.
you need to have some consistency here. We need to get you to do something consistently because this is a motor pattern ingrained in your brain and you know, we need at the beginning, we need to do more is more. And then at the end, less is more, especially with people who are hypermobile. They're just going to do what they know best, which is just sliding back and forth into that pattern or that the path of least
Mm-hmm.
resistance, right? So I told her to cut back a bit on the yoga the last time I had seen her, just because it was just not. I didn't think it was really helping her as much. She did go, but not as much. But she did not do any of the twisting.
Mm-hmm.
Okay, so when I saw her back in November, which is recent, a couple of weeks ago, that was my second visit for the back. So I didn't see her much for the back. She basically I rechecked everything: lumbar forward bend, back bend, side bend. They were all provocative.
Mm-hmm.
Okay, and because her back actually was more exacerbated than when I'd seen her 2 months prior. I ended up doing. I don't know. I don't do these that much. I think I learned these in school years ago, but these sitting stability tests through the arms. Do you do those at all? Flexion, extension, stability, and sitting at all?
I have not. You know, we talked about that a little bit when we talked about the lady with the shoulder pain because
Yep.
she was unable to hold her arm out in front of her and hold. But I have not really done a lot of that in sitting. I've done it somewhat, you know, in standing a little bit, having them shift their weight to find a, you know, kind of a point where they can hold a little bit easier.
Mm-hmm.
But I also tend to use, you know, pelvic floor activation with the stability stuff, because if they can activate their pelvic floor in different positions, and that kind of helps them know that I'm probably pulling in a
Right.
little bit better with some better recruitment here. But
Correct.
there's nothing wrong with the arms at all and the legs. And in fact, that fits in with an article by Kohler in 2012 in JOSBT, and looking at the diaphragm and what happens to the diaphragm in patients with back pain and patients without. Clients with
Mhm.
back pain and clients without, and the recruitment pattern change in the diaphragm. And,
Mhm.
they look at the arm, against, resistance, and leg against resistance. Of course, they're in supine instead of standing or sitting, but that the idea behind it, I think, remains the same, which is great because it brings up the point that maybe her diaphragm is over recruiting in an effort to help her, because she's moved so much at T12L1, which
Mhm.
is where the diaphragm is. And maybe
Mhm.
that, the diaphragm and some of the back extensor muscles are really being over recruited because she's just not getting the oomph
Yes.
from, the deeper core up, segmental motor control, as we were
Mhm.
talking about. And so in the face of that, they're going to over recruit quadratus, and the diaphragm feeds right into the quadratus and
Yeah.
and
Yep.
those muscles there in the posterior abdominal wall.
Yeah,
So
no,
that,
that's all.
I think that bringing that up makes that kind of like, maybe I need to rethink that just a little bit in the clinic myself, as a way to kind of see, people's buckle points, because it
Right.
certainly fits with the literature and the research. So that's a great point. I love it.
Yeah. Yeah, no, I don't do those that much, but
Mm-hmm.
I basically had her in sitting. I just, had my, one hand, she basically had both of her arms out at 90 degrees. I ended up
Mm-hmm.
pushing down on them with my other hand, with one
Mm-hmm.
hand, and my hand
Mm-hmm.
was just monitoring her lumbar spine. So she was resisting into extension, and that really flared, that like really
Mm-hmm.
provoked her symptoms. So of course it did, and then I
Right.
went the,
It
then
went
I
right
went
into a pattern. Mm-hmm.
exactly. And then I went the other way where she was stabilizing into flexion and she was fine. I'm like, of course, that makes sense.
And that, yeah, because then she was able to recruit her abdominal wall easier,
Exactly.
right? And probably
Exactly.
lats,
Yep.
when you're doing that coming down part. So, you get the posterior lats, the anterior abdominal wall, or, the lateral abdominal wall coming in. And,
Hmm.
that is probably something that's very important, because then you're bringing in some tension and integrity into the thoracolumbar fascia, which
Hmm.
is going to help pull her out of extension, or pull her out of her pattern of extension, because that thoracolumbar fascia is going to pull back on the spinous processes.
Yep.
So I love it. I'm
Yep.
putting this back into my thing. This is great. I can't wait. I've
So
got a couple of people I'm going to see tomorrow that is like, we're doing this right off the bat.
I know.
I kind of do it, but I haven't really done it intentionally I love it. It's
Yeah.
great.
Yeah. And it was interesting because so I said, well, now we know what takes your symptoms away. And she's like, yeah,
Mm-hmm.
she's like, wow, I was thinking of doing Pilates. I'm like, well, let's just hold off for now and just. So then I ended up having her get on her hands and knees. It's not a test I do often, but having come back from Shirley Sorman's course back in October, what's one of their standard tests is on all fours.
Yeah.
Once again, I don't do it often, but I said, look, get on your hands and knees, just sort of rock back, and obviously no flexion. I said, let's start here. Do a posterior pelvic tilt. Just really try to round your lumbar spine on all fours, and just
Mm-hmm.
let's try and sit back here, okay? Zero. I mean, I got her like
Yeah.
halfway.
Yeah.
Nothing.
Mm-hmm.
She couldn't do it. She couldn't
Mm-hmm.
do it. So I said, okay, let's start here. Let's just go into neutral, go into a little bit of a posterior tilt and see if you can go down. So I got her a little bit more. So when she goes into that full sort of thoracolumbar flexion on all fours, I was getting nowhere.
Right.
Okay.
Right.
So I said, try an extension, which I knew she would do no problem, which she did. So, I mean, really arching her back. And then,
Mm-hmm.
so I said, let's go to neutral, do a little bit of a posterior tilt, recruit your abdominal wall, and see if you can go down. And so she went down partly. I'm like, stop there, go back. So
Mm-hmm.
actually, I started doing a little bit of that with her. Any movement that I gave her, I said, you need to start with a bit of a posterior tilt, or anyhow, any way, shape, or form you can recruit your pelvic floor, or your lower abdominals. You need to start there,
Mm-hmm.
okay? Because I felt that she just was not able to recruit them. So I said, let's go to standing. So I said, do a little bit of a posterior tilt and stand, just a little, and bend forward. She couldn't even drop her head. That is
Mm-hmm.
how she could not. She was so fixed in that extensor pattern. So what do you
Mm-hmm.
think of that? I mean, I said to her, I said, look, let's start from below. Let's do a little bit of a posterior tilt. Let's get you out of that lordosis. For her, a posterior tilt was probably neutral for most people, right?
Mm-hmm.
And recruit your abdominal wall. Let's do a slow forward bend to see if you can actually turn those lumbar extensors off, right?
Mm-hmm.
So, do you have any thoughts on that, or should I continue?
Yeah, no. To me, this is typical short girl syndrome.
Yeah.
They're going to stand and bring their head up and their thorax up because they're living in an average world, and they're not average, they're short. And so their whole life has been, everything is up above where they
I
can see.
love it.
And so
Short girl
everything, I know, but
syndrome.
it
I
just,
love it.
but it's true. Well, see, I'm a short girl, so, and I'll tell my husband, that this doesn't, if it's above this shelf, it doesn't exist for me. I don't see it. I just, but I mean, you spend your whole life with your head up in the air, looking up, and the whole posture follows that.
Totally.
And so not only with dance, so she learned to move where she could in dance, but she had this, so this is a big one to change for her, and to, because especially if it makes her feel better.
Yeah.
So the idea here is that her brain has set up these patterns because it's the way she can move through her life.
Mm-hmm.
But can we change it enough so that she has enough variance, so that she has some movement variability in there to get her out of the sensitized system, or
Yeah.
segments, or whatever may be going on there.
Mm-hmm.
But it's very interesting when you get people, you can actually, if you have people who can't get on their hands and knees for whatever reason, you can do it leaning over a countertop as well.
Countertop. Yeah. Yeah. Great idea.
And, kind of, it's just a matter of, giving them two other fixed points. So either their knees in their hands or their feet in their hands, to be able to kind of start to try to gain some control through the pelvis and the lumbar spine,
Mm-hmm.
that maybe they can't do on two fixed points of their feet.
Mm-hmm.
So, which is, I know that's why the Sarman group kind of starts that way, because it gives them other points, to give stability, so that they can try to get mobility where they don't have it.
Right.
And somebody like this, who's standing on her feet, is going to fall into that pattern. It's going to be very difficult for her to break out of it.
Mm-hmm.
So I love the fact that you got her on her hands and knees, or just some other way, because one of the things you want to feed into her too is the bike. So here's the perfect person to get on hands and knees, because if she can start controlling this on hands and knees, or feet and hands, whichever way, because that's what the bike would be, right? Then it's going to translate over into her spinning, and that's where you're headed, because that's what you want. She wants to be able to teach spinning and not hurt. She wants to be able to go to yoga and not hurt. So yeah.
No. I never thought of the analogy with on your hands and knees and spinning, but of course that makes complete sense. You're just mirroring the image onto the. Yeah, exactly. That's awesome. So basically, what I ended up doing a lot of that with her the first visit, on the hands and knees, and I said, let me try the tape again. The posterior compression didn't work as well this time, so I took it off immediately. Okay, so what I ended, because she'd respond well to taping, and I wasn't going to see her for a couple of weeks because of my travel schedule. So I said, let me just put some, just from both of your proprioceptive cueing, just a piece on bilaterally, so diagonally around like the 12th rib, 10th rib, going up the same thing on the right, same thing on the left, hypofix the Luca tape, almost like an upside down V on her back, right? Just for some stability. I had it crossed midline, so it stabilized that, quote unquote, stabilized that area, which was highly, hypermobile. It was more, I'm like, she's like, are you like preventing me from moving there? I'm like, theoretically, yes, but I'm just trying to give your nervous system another option to move. And I love that. I tell that to my patients all the time, because I don't want her to get fixed on, my hypermobile segment. It's not going to, that type of thing. So I did that. And then she went away, and then I just saw her this past week. So I haven't seen her a lot. And she came in, the taping was amazing. I said, well, it gave you some input. She said her transition on the bike was a lot better. Her sleeping was much better, but still an issue. I'm like, well, I don't expect to get you miraculously better, since you've had this symptom for so long in one visit. But it was really the sleeping that was bothering her at this point. And but I know that she needs a program, which is what I want to talk about, of some basic movement exercises to really get her into that flexion pattern. So what I did, I treated her similarly, and then I actually wanted to get her to start to do some things on some of the Pilates equipment. I gave her, so this is what I want to just talk about briefly. she obviously does better with the posterior pelvic tilt and having some weight in front of her to recruit her abdominal
Mm-hmm.
wall. So I said, since you're sitting, you're squatting, I gave her some squats. I said, you need to have some weight in front of you, not 1 pound, not 2
Mm-hmm.
pound, not 3 pound. You need to have some weight that's going to cause this feed forward mechanism in your brain to turn on your abdominal wall.
Yeah.
I said I would even go up to 8 to 10, but so we started with 4, and she's like, oh, I actually feel my abdominals. I'm like, that's what I want.
Mm-hmm.
I don't want a 1 pound weight in your hand. People
Mm-hmm.
who are hypermobile do better with resistance.
Yeah.
So I had her start off with a little bit of a posterior tilt, put the weight in front of her. I had her go up and down squat on and off a Bosu ball,
Mm-hmm.
basically, and I taped her as well, the same tape in the upside down V on the thorax. I have a piece of equipment on the Pilates. I had her do it's called a Wunda box. I don't know if you know the
Mm-hmm.
box with the springs. I had her basically put both of her feet on the moving part of that box to do
Mm-hmm.
like a pike, almost like a
Yeah.
pike to recruit
Yeah.
her abdominals. So I had her do 2 springs and 1 spring, and she is interesting. She actually was pretty okay with that, which was shocking to me because I didn't think she'd be able to do that. And I'm like,
Mm-hmm.
what is she using here? She's obviously using her abdominals, but she said that because I said, let's just do a few. So maybe it's the endurance of the abdominal wall. She did about 10 and she's like, oh, I really feel that. I'm like, okay. Because I thought she'd have a lot of problems with that, but she didn't.
It's interesting because a lot of
Yeah.
times we think that it may be a strength or force production problem because they haven't used it in a while. And simply when you get people into, just a different movement pattern that's going to require muscles to switch on, once they get the hang of it, they can do it. This is just a coordination problem that, those muscles were never called into play
Yeah.
in that way. And you put her in a position where they actually had to work and she could do it, which is really cool because then you can convince them, look, it's not a strength problem.
Mm-hmm. Yeah.
This is where the postural variability will really help you.
Mm-hmm.
Because you can feel that in different positions, you can get different muscles to turn on and work for you. So we don't want to keep you in the same, dominant pattern that you're in all the time. We want to give you that variability. So, and again, here, Erica, I love what you're doing because you had her hands on the box and her feet on the springs.
Yeah.
And again, that's a variation of that kind of pitch forward,
Mm-hmm.
posture on the
Yep.
bike.
Yep.
Which is like very cool.
Yeah.
So, but it's really interesting to just kind of give people the, let's just see what happens with this and see what you can do. People can do so much more than we think they can.
Yeah, no, for sure. Absolutely. And I think that's it. When I was picking the box, I know she doesn't have access to that, but I was like, let me just try that. But it's true. It's the issue, short of trauma, surgery, or, falling. It's something these people do all day long. And she spins, she teaches a lot.
Mm-hmm.
Hands on the bike, feet clipped in. If you can reproduce that movement pattern outside that studio and start moving in and out of different postures, mimicking that 4-point kneel, that, I think for her was very helpful. And I got her on the Cadillac doing some, just some very interesting. I had her on the Cadillac with the bar,
Right.
doing some seated
Mm-hmm.
push downs.
Uh-huh.
And when her hamstrings were on stretch, like she couldn't really sit. She couldn't really sit with her legs straight
No.
without going into that, she couldn't do it. She couldn't even
Right.
flex. So I just had her bend her knees a little bit and I had her push down, and of course immediately she felt it in her back. I'm like, oh,
Mm-hmm.
So
Did you try putting like a couple of folded blankets up under her pelvis to get her higher?
No, I didn't. That's a great idea.
Yeah, because it may be that the hamstrings were over recruiting and pulling her, and that's why it didn't feel good.
Yeah.
But I like what you were trying to do because, again, you were trying to bring in the flexion of the arms, because I was going to suggest what was a roll down going to look like with her, holding the bar in the springs. Would she be able to do it, or did she have the range of motion yet?
It's funny because she said to me, because she's done Pilates before, she's like, are we going to do roll downs? I'm like, not today. And it's funny you mentioned that because I said to myself, I would have liked to have seen that when I was writing the note up, but I'm seeing her in a couple weeks.
Mm-hmm.
So I'll do that. But my guess is she probably won't be able to do it.
No, but maybe with her knees bent, she could.
She could, for sure.
Mm-hmm.
So then I had her do some just like little leg springs, everything basically just trying to get a posterior tilt. And then I just had her do some leg springs, lying supine on the plinth, on the Cadillac with the straps wrapped around her ankles, just doing easy pushing. I just wanted to see if she could do it. She had no problem with that at all. And so that's where I ended it. Okay. And since she needs so much of this sort of flexion base stabilization, I thought from a progression, and tell you what I would do. Maybe I would can hear your thoughts, and we can end it there. But I think that I would love to put her in like a full kneel, half kneel, doing something with a weight in front of her, or doing some PNF, easy sort of chop patterns at
Mm-hmm.
some point to get a recruiter abdominal to sort of bring her from half kneel, kneel. I almost would love to have her do like rolling patterns on the floor, and then start to progress her to more. You know, mimicking things with the bike, doing some squats with more weight in front. I don't know how I could progress anything on the box at this point because the springs were just at a very difficult level to begin with. I can do more endurance, but what are your thoughts on just people like that? Because it's obvious what her issues are. She cannot flex. She needs to recruit her abdominal wall. She's short. She's a spin instructor. In terms of an exercise progression, what would you do in a situation like that?
So some of the other things that you can do to really kind of progress her up from bilateral knees to actually standing, as some of the things that I do is because in people we have talk about this all the time, and it's like they need to appropriately learn how to use the flexion pattern better. So I'll have them on hands and knees with some sort of resistance band around their thighs so that it's pulling from behind, so that they have to actually pull forward with the, they have to bring their knee closer to their chest. So
Got it.
we're working that way. And or I'll have they have the therabands around their arms coming back so that they have to pull back, so we get some latissimus activity along with it.
I love it.
Sometimes you can just have them on their hands and knees with their hands on the bed and just have them push towards their knees, and that can bring that stuff on and begin to give them something to automate. I always add exhale with it, because with flexion, exhale goes really well. And or with her as a fitness instructor, I would have her talk, because she needs to be able to talk and do this stuff.
Yeah.
And so she's got to train exhale for all of that. And, she may, it's going to only help her being able to yell over the spin mic, if she's got good vocal control with exhale and those patterns, so that it kind of feeds into that thing that she needs to do. But I like doing stuff like that, and then I'll put the resistance band, around the pelvis and have them walk.
Yeah.
And pull, and so that they're pulling into the, and with her, you might even find that, putting it at the level of her diaphragm or around her midsection, there may be another point for her that's a little bit better, but she did so well at the pelvis.
Yeah.
That's kind of a great thing. And people go, well, you're just feeding into, tight hip flexors. And it's like, no, I'm because when they're walking, one has to recruit differently than the other.
Right.
And so what I'm trying to do is load eccentric hip flexion or load eccentric psoas on the side where the leg is straight.
Yep.
As they're working. So what I'm doing is actually trying to get the pelvic halves to kind of start working reciprocally and not together.
Right. So
because when they're in extension pattern, they just pull together. They don't pull, so that's why I have them do walking or step ups.
It's interesting you say that, because when I first evaluated her, I applied the bilateral anterior and the bilateral posterior compressions. The best was the bilateral posterior, and the second best was bilateral anterior. When I did the oblique compressions, asymmetrical compressions, they made her worse. So that's what she needs to train.
Yeah.
And so
you can do that with step ups. You can do it, and they doesn't have to be high step ups. She can be a low step up with the resistance band around her with the force, pulling from behind. And she can work on step up, step down, step up, step down. She can work on taking steps. There's a lot of fun things she can do with that. Plus, it'll help make her stay on one side versus the other. It'll help her kind of move off of what you said she was right. Yeah, right. Shifted to the right.
Yes.
So it, can help bring that in. And, you can, so that works. The other thing, if she's a real high level person, I would have to wait until she was like really super good at being able to really get, like in a prone plank type position and really control that without using her extensors.
Yeah.
It's going to be a challenge for her. But if she ever could do it, you could put her legs, into the resistance band or something like a TRX and have her just bring one knee up to the chest and the other knee up to the chest. But that's really super high level. Maybe with the knees bent again. That's why I like doing that. in hands and knees,
Mm-hmm.
because they
Yeah.
can slide their knee forward and then they can actually actively pull their knee forward, and so then they can, it just
Yeah.
feeds into that reciprocal kind of movement that you're looking for there. And that makes sense with the bike, because the bike is reciprocal.
Yeah. 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 So the band would be around the thighs,
Uh-huh.
and then you could also around the arms. One band, correct?
Uh, well, you could do two bands. I usually do two, one on
Yeah.
each leg.
Was I was going to say because
Yeah.
because
And
I've
or one on each arm.
right.
I
Yeah.
just, because I like the body that, if we're going after segmental,
Yeah.
motor control and motor recruitment,
Mm-hmm.
the less symmetrical I can be with them, the better.
Yeah. Yeah. Exactly.
So if they have to deal with their own bands on each leg, then that makes them have to recruit different than if they've got
Yeah.
one around.
One on one. Yeah.
Then the stronger leg can still kind of win.
Yeah. And then with the
You know?
band around exactly.
or the more coordinated, or whatever side the
Yeah.
pattern can kind of still win in that
Yeah.
position. That's why when you put it on the Cadillac with the separate leg springs, they have to cope with it differently.
Yeah. Yeah.
And because they don't have the other, they don't have the pattern to they can't go into their pattern,
Yeah.
as a recruitment device anymore.
Yeah.
And you have their legs separated on those springs, they have to cope with it differently.
Yeah, it's interesting. So when you put the band around the pelvis when she's walking, same obviously one band, but then it's
Yeah.
gonna cause her to eccentrically load those hip flexors. So those are all great ideas, and I think it goes back to just at the beginning the assessment. The asymmetrical stuff made it worse. So she needs
Yeah.
to really train that, and obviously. People like her, hypermobility and control, it doesn't happen overnight because
No.
these people are so used to, and I'm a hypermobile myself, we're so used to doing things quickly and easily, and let's do it until like we run out of options. And her buckle point, I think she was made aware of her buckle point, quote unquote, right?
Mm-hmm.
Because now she's like, oh, so I had her also, I said, when you're on the bike, just because there's a weight section in the class, I said, just push your hands lightly down on the handlebars to recruit your lower abdominals. Just while you're spinning, just do a gentle push down, right?
Mm-hmm.
Just to get her more aware of that as well while she's
And
spinning.
again, that starts recruiting lats, which is going to
Yes.
help the tensor fascia,
Yep.
the thoracolumbar
Thoracolumbar
fascia
fascia.
to have a little bit of tension through it to help, to passively, because it's a passive restraint system. It just is going to help passively control that lumbar spine a bit.
Yep.
So
Yep.
it just won't be
Totally.
hanging in lordosis, especially if she's sensitive in that position.
Yeah. Totally. So that's awesome. So I'm actually
Cool.
going to be seeing her now once a week. So I will report back, or because this is a common scenario, and I think these people get lost in our system, and I think that we need to, as a profession, really need to stick with this population. So
Mm-hmm.
it's great suggestions. Awesome. Thank you,
Yep.
Susan. Cool.
Lots of fun.
Lots of fun, everybody. Thank you so much. And we have our website, tough2treat.com. We have a couple of PDFs on there for you guys who are not subscribers onto our list. If you sign up onto the list, you'll automatically get the PDF. I have a chapter for my book, and Susan has some awesome things regarding sleeping and breathing and things like that. So tough2treat.com. And if you have not left us a review on iTunes or Stitcher or Spotify, please do so. We would really appreciate it. We're trying to get this podcast up into the top 10 would be in health and medicine. It would be awesome if you could help us do that. Thank you, everybody.
Bye.
Bye.